Assalamu alaikum everyone. Am I audible?
Walaikum salam, yes.
Okay, let's start. Welcome to the Neurosurgical Case Room. This is the part 2 of Parasagittal Meningiomas. And we did discuss the relevant anatomy yesterday, and especially the venous channels, etc. So we are going to proceed with the clinical presentation, with the classification and the radiology today. Regarding the surgical planning and the surgical nuances, we are going to have a completely different, a separate session for it, because it would have made this session really heavy. So now let's start with the classifications. We have two classifications here. The one is something which we all know, widespread, and it's something we narrate in the rounds, it's something we narrate in the OR, etc. It's the Sindou grading. Apart from Sindou, there is another one which is just a slightly modified way of Sindou. It's Brocchi classification. So, I'm not sure how many of you are familiar with it. I personally have never used it during my own clinical practice. I'm not sure about anyone else, if somebody uses it, or this is just a textual thing, but let's get through it. So we have 5 types in comparison with Sindou, which has 6 types, right? These are 5 types. Type 1 is just the outer surface. Type 2 is the lateral recess. Type 3 is one wall is invaded. Type 4 is 2 walls of a still patent sinus. And type 5 is when it spreads over the midline, invades the 3 walls, and occludes the superior sagittal sinus. So let's draw an illustration so that we can understand it better. We can draw the sinus. The yellow things are the hemispheres. The blue thing is the sinus, which is, I think, understood by the color of it. And then we have the lesion, which is growing in, let's say, green. So type 1 is going to be this. This is going to be type 1, when the tumor is attached only to the outer surface of the sinus. Type 2 is when this tumor enters the lateral recess of the sinus. So it is still mostly outside, but it is invading the lateral recess, and that is going to be type 2 of Brocchi. Then we have type 3. The tumor invades one wall of the superior sagittal sinus. So this is how it is going to look like. This is type 3. For type 4, it needs to involve at least 2 walls. So this lesion could go like this. Let's draw a bigger meningioma, which is invading both these walls. So this is type 4. Type 5 is when it is spreading over the midline and invades the 3 walls, occludes the superior sagittal sinus. So this is going to be type 5. This is Brocchi classification. It sort of overlaps with Sindou. We are going to take a look at Sindou as well. Am I clear so far, or am I going too fast?
Clear.
Okay, let's move to the next classification. This is Sindou. Sindou is relatively easy. We have all grown with it. Tumor 1 is when it attaches to the outer surface of the sinus wall. Type 2 is when it is inside the lateral recess. Type 3 is when it involves one wall. Type 4 is when it involves lateral wall and roof. Now, roof is the portion where, it does not get addressed in Brocchi as a separate structure, whereas Sindou addresses it separately. Type 4 is where the lateral wall and the roof, they are both involved. Then we have type 5, where there's complete sinus occlusion, but one free wall is still going to be there. I'm going to draw, even though we have an illustration ahead, but let's draw nonetheless. Type 6 is there's complete sinus occlusion without any free walls. So I am only going to draw the sinus here. This blue structure is sinus. And let's stick to the green for the tumor. Type 1 is when this thing here is type 1. It is only attaching to the outer surface of the sinus wall. Whereas type 2, the fragment is going to get inside the lateral recess. This is type 2. Type 3 would be when this entire wall is involved. Type 4 is when the wall is involved along with the roof. So if you see the involvement of roof, then this means what grade is this? This is type 4. Type 5 is complete sinus is occluded except this contralateral wall. So you only see this contralateral wall. Rest of it is occluded, completely occluded. Type 6 is also complete sinus occlusion, but there are no free walls. So all you see is tumor in the sinus. Now there are two important things to remember. You all need to remember that the radiology can be very, very deceptive. So there have been instances where a sinus looks like it is completely occluded on the preoperative imaging. But when, and there have been case reports that when the surgeon operated, they found that the sinus was not completely occluded. There was some flow. Comparatively, if it looks like it might not be completely involved, operative findings do not have to correlate with the radiology. There could be complete occlusion despite looking like one wall is free, etc. So always remember, radiology is your guide, but it can be deceptive as well. Are we all on the same page?
Yes.
I'm sorry for the background noise. We have some construction going on. So this is an illustration, pretty much everything that I described in the previous slide. Type 1 is you see the attachment to the lateral wall. Type 2 is you see the involvement of the lateral recess. Type 3 is the lateral wall is involved itself. Type 4 is wall along with the roof. So remember, from type 4, there is a wall plus a roof. For type 5, we have walls and the roofs and complete occlusion. 5 and 6 both are occlusions of the sinus. So now we are not talking about walls, we are talking about the level of occlusion. Type 5 is also occlusion, type 6 is also occlusion. The only difference is one free wall. If we have one free wall like it is here on this side, this means this is 5. If you do not see any free wall, and the tumor has completely spread over the midline, it is reaching up to the other side of the hemisphere, then that means this is a type 6. Let me clear. Let's move on. Presentation is vastly variable depending on where the exact location of the meningioma is, how much is the peritumoral edema, what is the size, etc., etc. So it depends on a lot of variables. Also, we did discuss yesterday, parasagittal meningiomas have a higher propensity to be of grade 2 or grade 3. If you compare them with, other locations like convexity, like skull base, these meningiomas have a higher risk of being a grade 2 or grade 3. Apart from that, the other problem is in women, parasagittal meningiomas are more likely to be grade 1, whereas in men, they are more likely to be of grade 2 or grade 3. Semomatous, we know they are one of the most benign types. Even in the grade 1, they are least likely to recur, whereas, angioblastic subtype, even though it is among grade 1, it is most likely to recur. Apart from this, let's discuss the clinical presentation now. We know that the most common presentation is seizures. Patient can have a variety of seizures depending on the exact location. It can be a Jacksonian march. It can be a sensory sort of seizure. The second most common presentation is contralateral hemiparesis. Especially if a tumor is growing in the location of, convexity sort of, where it is involving. Let me draw here. For example, this is the superior sagittal sinus. That's the skull. So if a lesion is growing from here, it is involving the superior sagittal sinus, but it has also grown laterally towards the convexity or the superior portion, then they can present with the foot drop, with contralateral hemiparesis, with monoparesis, etc. Posterior third can present with visual symptoms, which visual symptoms we are going to discuss location-wise. Another caveat is that anterior and posterior third lesions can go undetected for longer because the regions, even though they are eloquent, they're not as eloquent in comparison with the middle third. With the middle third, let me draw here. Give me a minute. So with the middle third, we know we have the central sulcus here. Along with the central sulcus, we have the motor cortex, we have the sensory cortex. So this region is a high density eloquent region. If anything is going on, it is a lot more likely to present earlier, whereas the anterior third lesion it can go undetected for way longer because the patient will have personality changes, etc., etc., very vague symptoms, which usually get brushed off in the doctor's clinic until and unless they get an imaging. Posterior third can present with visual symptoms, but it can also go undetected for longer. So middle third, even though from a surgical point of view, it is more difficult, for the patient, it is better because it presents early due to the structures it is involving. Let's move to the location-wise presentation. Anterior third presentation can overlap with the normal frontal meningioma, which is around the convexity, or olfactory tube meningioma sometimes, depending on how inferiorly it is extending. There can be progressive personality changes. There can be apathy, abulia, depression. There can be cognitive decline. Sometimes, mistaken for dementia. Sometimes for primary psychiatric disorders. I remember having a patient last month in my clinic, and she only presented with dementia and some memory impairment. There were some personality changes, and she was 65, 68 years old, something. So her family thought that probably, these are age-related changes, etc. I have no idea how they got a referral to neurosurgery. Whoever referred her, kudos to them, because these patients usually spend years, and she was on a lot of antipsychotics for her medicine. When we got the imaging done, she had a meningioma, which was huge. And that's a very common story if you end up reading the case reports of meningiomas, especially in the frontal region. This is a very common story. Apart from that, you can have gait disturbance. The patient can have ataxia and apraxia both. Can somebody let me know what is the difference between ataxia and apraxia? What happens in ataxia and what happens in apraxia? Am I audible?
Yes.
Okay. Are we going too fast today? I do have a commitment to keep after this. I'm not sure. Are we going too fast or you guys are okay with the pace?
It's okay, but difference
The
is
pace is okay. The pace is okay.
So what is the difference between ataxia and apraxia? Nobody? Ataxia, in simple words, very simple words, ataxia is imbalance. It's like an actual imbalance, and can have a variety of reasons. Could be cerebellar, could be spinal, etc., etc. It is related to balance, and patient will have drunken gait, sort of, right? Apraxia is a different thing. Apraxia is when the patient is going to have a difficulty in initiating the movement. So they would look sort of frozen or glued to the floor. And this usually happens in the frontal region, sometimes in the patients with hydrocephalus as well. Yes, Dr. Lalita, patient has a harder time in starting purposeful movements. So the motor pathways are completely intact, but they have a difficulty in initiating. The initiation is affected. So frontal region tumors usually present with apraxia. Gait ataxia is a lot more common in either the cerebellar posterior fossa lesions, or when the posterior column is affected in the spinal cord. I'm probably, I'll try if I can leave a small table comparing both of these on the WhatsApp group after this session, inshallah. Apart from that, we have anosmia. A patient can have anosmia if the lesion is extending inferiorly far down to the olfactory groove, depending on that particular presentation. For the middle third region, the para-Rolandic, the central region, which we discussed yesterday, starts from coronal to lambdoid suture. The most common presentation would be seizures here. These could be Jacksonian motor seizures. These could be sensory sort of seizures. And they don't often have to be Jacksonian. Could be other types as well. But Jacksonian gets thrown as the prototype of this region's. Then we have monopressus, hemipressus, depending where exactly and how far the lesion has got. If it is still sticking close to the midline, patient can have contralateral foot or leg involvement. If it is big enough, growing towards convexity, it can also involve the leg, the arm as well. So let me draw. This is the midline, and we all know that the leg and the foot is somewhere here in the midline and in the medial portion. So if a lesion is growing big, the first presentation is obviously going to be the foot and the leg. But if it goes big enough, or if there is significant peritumoral edema, which is extending towards the lateral side as well, then the patient is going to have involvement of arm and very less likely face. Face is usually not common until unless it's a lateral convexity lesion. Depending if there is significant peritumoral edema, patient can have involvement. Most common involvement is still going to be foot. Foot drop is an option. Apart from that, patient can have monopressus. Patient can have hemipressus as well. Now, there is another rare presentation that I have not seen personally in my clinical practice, but the books reported. If this lesion, it's big enough or there's significant midline shift here, and that is causing pressure on the other side as well, patient can present with a bilateral leg weakness, which mimics a spinal cord lesion. So there can be a false localizing sign as well. I have never personally seen this happening. I have seen the facial involvement, brachiofacial involvement, but I have never seen this happening. This is something that textbooks report. I found it interesting, so I thought maybe I would include it. Apart from that, patient will have cortical sensory loss. They will lose two-point discrimination. They will also lose digraphesthesia, primarily affecting the lower extremity, because we know the primary sensory cortex is also going to be here. Are we all clear?
Yes.
Okay. So for posterior third, we know it can present with visual field deficits, contralateral homonymous immunopia, could be lower quadrant anopsia, depending on where exactly the lesion is and how far behind it reaches. If it reaches the visual cortex, patient can have heminopsia with macular sparing. Sometimes macula is also involved. Quadrantanopsia is also a case if only the radiations are getting involved. Apart from that, if the dominant parietal lobe is involved, there is a particular condition called visual agnosia. Patient will have difficulty recognizing visual stimuli. Let's move. We are running out of time. So this image is here. We are going to discuss radiology separately. This image is here to show only one thing: the calvarial bossing. So before the CT and the MRI imaging was widely available, calvarial bossing was one of the telltale signs. We do not usually see it. I have seen one case with calvarial bossing, but it was of hemangioparasitoma. When the patient came with a huge head that looked like this, and there was significant boosting, there was significant bony involvement, etc. Can somebody, while we are at it, and the imaging looks relatively similar, can somebody from the audience turn on the mic and let me know what would be some easier ways to differentiate between hemangiopericystoma and meningioma radiologically? And by the way, this thing is now called solitary fibrous tumor. Just so we are on a clear note.
Okay. I think hemangiopericystoma is a differential for meningioma, and hemangiopericystoma tumors are, I think, more vascular as compared to the meningiomas.
No. I was asking the radiological differences. How would you look at if let's say you get a certain image and you think whether this is meningioma or this is more likely hemangiopericystoma?
So in meningioma, there will be like clear signs of extra-axial lesion, while I think in the hemangiopericystoma, there be less likely to have some signs like CSF and all that. Secondly, there be more fluids in the hemangiopericystoma as compared to the meningiomas, I think. And the convariant inversion is more in hemangiopericystoma as compared to the meningiomas.
Okay, Dr. Noor, I was only able to hear part of your answer. I think there is some problem on your end regarding the audio. So, yes, fluids are the good answer. Apart from fluids, what other things can we see?
I think on the CT, we can differentiate via the bone changes. So,
Exactly. What is that?
so on SFTs, it will be destructive. So it will have an osteolytic appearance.
Exactly.
As for intraosseous meningioma, you will see it as hyperostosis.
So can lysis happen in meningiomas as well? What if I say that, okay, this patient is a biopsy proven meningioma, but they still have the osteolytic appearance on the bone?
It is possible for long-standing meningiomas where commonly I think we see it not on the calvario but more on the skull base. It can have lytic appearance as well.
Yeah. So for hemangiopericystoma, the lesion is obviously going to look a lot more aggressive. There are going to be fluids. There's going to be significant, peritumoral edema. And apart from that, you might see some calcifications, but then that is an overlapping feature. One feature that will probably alert you to the presence of a solitary fibrous tumor is the osteolytic appearance. It eats up the bone very aggressively. Usually, meningiomas cause hyperostosis. The only situation where a lysis is going to be visible is when the meningioma was long standing. There were significant pressure symptoms, and the calvaria just, gave way to it. So, also the history is very suggestive. Meningiomas usually have a longer history. Hemangiopericystoma have a relatively shorter history. So CSF cleft sign, Dr. Sophia, sometimes hemangiopericystoma can have CSF cleft signs, and I am not sure about the mother-in-law sign. Do you mean the contrast delay? Let's move to the next slide. You can see the hyperostosis here, along with the hyperdense appearance of meningioma on the CT. So we are going to discuss the radiology separately. And on non-contrast CT, they look hyperdense. We just saw an example. We have another example ahead of us. They look hyperdense. Sometimes they can be isodense. Sometimes they're so isodense that it would be difficult to identify on a CT. They are well circumscribed extra-axial masses, often abutting the midline, sometimes causing midline shift as well. Calcification is present, and usually calcification is a good news because this means it is more likely to be a pseudomatous subtype. On contrast enhanced CT, we usually don't get contrast CT anymore, especially if an MRI is available. But you should know that there is a homogeneous robust enhancement. Bone windows are really, really important because we want to see if there's hyperostosis, if there's lysis, how much is the bone involved, and for our operative planning, because you cannot plan your flap until and unless you have seen the bone. And the situation of the bone is also going to give you a clue of how much it will bleed. These hyperostotic bones are notorious for A, difficult flap rising, etc., and B, they cause extensive bleeding because the blood flow is a lot more than the normal bone. So for surgical planning purpose, you would need a contrast, you would need a CT bone window. This is the CT, and you can see the hyperdense lesion well described, abutting the midline. There is some involvement of sinus as well, but we can't be sure how much of it. Apart from this, on this image, you can see some peritumoral edema and a lot of hyperostosis on the midline, and the flap is going to be really difficult in this particular patient because A, the bone is very thick, and B, this seems to be around the coronal suture. And we already know that around the coronal suture, the bone is slightly more adherent to the dura. So this is going to give the surgeon a really difficult time. Let's move. For MRI brain with contrast, T1, they are typically iso to hypo, and for T2, they have variable signal. If a meningioma is looking hyper intense on T2, this means it's going to be softer, and we would have an easier time in taking it out until unless you see a lot of phloids. If you see a lot of phloids, then this means it's going to bleed more. Apart from that, if it is hypo on T2, this means that it is more of a firmer consistency, and the fibrous variant. The fibrous variant is going to be hypo, and the relatively softer variant is going to be hyper, because we know T2 measures the water content of any particular pathology. Apart from that, we are going to see the CSF cleft sign, which is very typical for extra-axial lesions. And there is a rim of T2 hyperintensity. Along with it, we have peritumoral edema. We did discuss this yesterday about the pile parasitization, that there will be, what will be the signs if, pile parasitization has occurred. The tumor is, meningioma is an extra-axial lesion. But if it is causing pile breach, which is a common pattern in grade 2 or grade 3 meningiomas, then the signs are going to be there. There will be no CSF cleft. There will be significant peritumoral edema, disproportional to the size of the lesion itself. I think I would have to call it off after the radiology section. So we have MRI brain with contrast, T1 plus contrast, and usually we have intense uniform enhancement. There are situations in which the enhancement is not uniform. Either the tumor has a lot of calcifications, so they appear as, hypodense dots. Apart from that, if tumor has some small pockets of cysts or small pockets of necrosis, then that will also lead to heterogeneous enhancement. Otherwise, meningiomas enhance avidly, intensely, and homogeneously. We can see the classic dural tail sign, which usually is going to tell us where the tumor was originating from. Apart from that, we are really interested in venous sinus patency. For that, we will need MRV and sometimes CTV. There are surgeons who would opt in DSA as well. DSA is the gold standard, but due to its lesser availability in a lot of setups, MRV usually serves good enough. So you see this post-contrast, the T1 weighted images of meningioma, and very interestingly, it is involving both the middle third and the posterior third. not reaching up to the toracula. The first three images are T1 post-contrast. The last one is T2 weighted image. Why T2? Because we are very interested to see whether the sinus is involved. And apparently it looks like the sinus is involved here. Let's see. On DSA, we have certain findings. Unfortunately, I could not find exact images to demonstrate these better, but it's really, really important to know there are certain signs which are very specific to DSA. We want to see the position of the internal cerebral veins, whether they are depressed, whether they are displaced downwards by the parasagittal tumors. Apart from that, there is one thing which is called closing of venous angle. If a lesion is more anterior, it can cause pressure on the thalamostriate vein and it can become, depressed, which is the venous angle usually looks like this. By the closing of venous angle, this is how it is going to look. The angle is going to be more acute. Apart from that, we have the other signs, which we know. There will be non-visualization of superior sagittal sinus. It won't opacify. Along with that, cortical venous interruption would be there. There will be stasis or delayed emptying. Contrast clearance is prolonged. I think this is what the Dr. Sophia meant by mother-in-law's sign. There's this joke regarding coming early and leaving late. So contrast clearance is prolonged here. And that is, I believe, called mother-in-law sign. I have personally never liked the name. Apart from that, there is one more thing that we want to see. We want to see if patient has any features of venous hypertension. There can be flow reversal, there can be collateralization. Why is that important? Because you want to be sure what direction the venous flow is reversed to. Yesterday, we discussed a few other groups. So we want to be sure whether it is draining towards the sphenoidal group, whether it is draining towards the tentorial group. So the collaterals, their flow and their direction can only be seen in DSA. You cannot assess the flow direction on any other modality. For that, you would need the DSA. And there are times when, the superior sagittal sinus is blocked. We discussed this yesterday. This was the acute angle that the vessel was making. And if, say, draw this. So this is the normal sign. And usually the venous flow is like this. But if there is venous hypertension, then the flow is going to get reversed. So assuming we have a tumor sitting right here, occluding the superior sagittal sinus, so the blood goes ahead, it recognizes that there is an obstruction ahead, so instead it tunnels down to the cortical veins and the venous flow is reversed. Sometimes this works as a life-saving thing because it is also channeling the blood. Other times it can end up in patient having venous hypertension. We are going to address venous hypertension as well, inshallah. So apart from that, we discussed that we want to see where the blood is getting shuttled down, if it is the transverse sigmoid sinus route, if it is the middle cerebral vein and the sphenoidal route. So that's it for today. The surgical indications and surgical nuances we will discuss tomorrow. Unfortunately, I have a commitment to keep today. Thank you so much for joining, everyone. Please leave me questions or any feedback you have on the WhatsApp group. See you all tomorrow, inshallah. Thank you so much.